Hi, it's Dr. Robert Seichert. Thanks for tuning in to episode number 46 of the Doctor Podcast Show, also known as National Eclipse Day. I hope you all had a good time watching the eclipse, but I hope you also wore your safety glasses. Today we have a great guest, Dr. Reed Caldwell. Dr. Caldwell is a board-certified emergency medicine doctor. He's a clinical associate professor of emergency medicine at the Ronald O. Perelman Department of Emergency Medicine at the NYU Grossman School of Medicine here in New York City. He's also the Emergency Medical Services Director at the NYU Langone Medical Center. And he is an expert on emergency rooms and emergency medicine, which is a very important topic because lots of people wind up going to the emergency rooms and they're very crowded lately, and it's becoming a bigger problem. So Reed, thanks very much for taking the time from your busy schedule to join us today. I really appreciate it. It's very kind of you.
Thanks for having me.
Yeah, it's great. It's a pleasure. Tell us about how you became interested in emergency medicine. How many years of training after the usual medical school training did it take to become a board-certified emergency medicine physician?
So I've always said I wanted to be an ER doctor since I was five. My mom would tell you 3.
Okay.
I was quite sick when I was younger, through high school and college with asthma, and I was in the ICU quite a number of times.
Really, the ICU?
From the age of 3, 4, 5. And I think that really planted a seed, and critical care and hospitals, nurses, physicians, respiratory therapists they helped me. The environment was comfortable for me, and I found it all quite fascinating.
Wow, so you got an early start in that. You knew where you were going.
I did.
How many years of training is it after medical school to become an emergency medicine doctor?
So, emergency medicine is interesting in the United States. There are not very many specialties are like this, but there are both 3 and 4-year programs. So I completed a 3-year training program, and then I went home to Colorado and worked 2 years as a community attending there, and then returned back to New York City.
Wow, so it's about 5 years in total. And now you're at NYU, which is one of the top medical centers in the country, if not the world, and also has a huge emergency medicine department. Can you tell us a bit about the NYU Medical Center, Langone Medical Center, emergency services that are available?
Absolutely. So I'm the chief of the department at Tisch Hospital, or the Manhattan NYU Langone Health Manhattan campus. We, as you said, are a very busy emergency department. Last year we saw over 100,000 patients in the year.
100,000?
Yep.
Wow.
And currently we're seeing over 300 patients a day. NYU has a number of different emergency departments in Manhattan, in Brooklyn, and also 2 out on Long Island currently. Each of our emergency departments is a little bit different. Where I work in Manhattan, we are not a trauma center, but we provide comprehensive services for most other problems or complex illnesses: stroke, heart attack, different kinds of GI interventions, lots of cancer, advanced heart failure.
Right. I know the residents who are doing emergency medicine training at NYU also rotate through Bellevue Hospital, right, which is the city hospital affiliate of NYU?
Absolutely. Our emergency medicine residency is the NYU Bellevue Emergency Medicine Residency. Our residents also, so they spend a large amount of time at Bellevue. They spend quite a bit of time in the Perelman ED at Tisch Hospital. And then they also spend time in our 2 emergency departments in Brooklyn.
So they get a vast experience in different types of hospitals. And Bellevue is a trauma center as well.
Absolutely. Both Bellevue and NYU Brooklyn, as well as NYU Long Island in Mineola, they're all level 1 trauma centers.
Right. That's why you see police officers and firemen, firewomen going to Bellevue if they get injured or have some issues. That's great. Right. Tell us why it's called the Ronald O. Perelman Department of Emergency Medicine at NYU.
So Ron Perelman, a well-known United States businessman, he's a donor to NYU and made a generous donation, and now we carry his name.
I see. Yeah, the building has his name on it. That's great that he did that and is helping people by. We used to have a smaller emergency room. Now it's a huge facility, so it's better care for patients. So why are emergency rooms and emergency departments so busy these days? A lot of my patients who happen to go to emergency rooms on occasion tell me there's a long wait, there's a lot of people, it's very crowded. Seems like they're getting busier and busier over time. Why is that?
I think that it's multifactorial. I can speak specifically to some of the things that are happening here in New York City, but similar phenomenon I think is happening in a lot of the country. One is access to primary care and preventative care. So both people being able to get in with kind of urgent and more subacute problems, having a hard time getting into a primary care provider. So if you're sick today, if you're sick tomorrow, if you're sick the next day, some people may not be able to get in their primary care doctor for a couple of weeks.
Can't wait.
And can't wait. Secondly, if people lack primary care, they're lacking early recognition of disease processes, and then some of those unrecognized or untreated can turn into emergencies like cardiovascular, untreated cardiovascular risk factors. So I think that's a huge part of it. And then, unfortunately, some hospitals are closing or beginning to limit services. So, then those patients have to seek care elsewhere, and the adjacent hospitals get busier.
Right. So the common denominator seems to be just reduced access to medical services, which eventually results in emergencies.
Reduced access to services, and then knowing that emergency departments are a 24/7 operation,
Right.
and many or most can provide comprehensive care. And in the United States, because of EMTALA, fortunately ERs are required to see everybody. And I say fortunately because that when EMTALA emerged, that was really became life-saving for people, and now is standard practice in the United States.
Can you tell us more about that? What is that, the EMTALA that you mentioned?
Yeah, so it requires that every patient in the United States who walks into an emergency department receives at minimum a medical screening exam to make sure that they are stable and or not in active labor.
Well, that's good to know for people out there who are sick. You can go to any emergency room
That's right.
and get treated. So in Manhattan and New York and everywhere else, I've seen a lot of urgent care facilities opening up. They're like little stores basically, and they sort of offer emergent or urgent type of service. Can you tell us what the difference is between an emergency room in a major hospital like at NYU Langone versus an urgent care facility that may be on a corner of a street?
Yeah, so it would be likely that the main difference is resources, both stuff, space, and people, or specialists. So
Right.
you walk into a large, particularly academic emergency department, and they will have the ability to onboard or utilize a wide variety of services, whether it be an operating room, a cardiac cath lab, specialized testing like MRI or echocardiogram. Most emergency departments will have the ability to either utilize those services or get you to those services when it's emergent, as well as the specialist to take care of all different parts of your body and all of the different problems that can happen. Whereas in an urgent care setting, it is more resource limited, and many are not open 24/7,
Right.
and are generally for more minor illnesses, aches, pains, minor injuries that don't require a more comprehensive team.
So if you're deathly ill, feeling really horribly sick, don't go to an urgent care facility in your neighborhood. Go to an emergency room at a hospital instead.
Exactly, particularly for things that may be time sensitive. So signs and symptoms of a stroke, signs and symptoms of a heart attack, somebody who is not breathing or who is having a really hard time breathing, maybe even changing skin color, severe abdominal pains, inability to walk and get up, somebody who's confused. These are things that I think of really require an emergency department evaluation. Things like sore throat, mild cough, some more minor sprains, soft tissue injuries, those may be appropriately evaluated in an urgent care setting.
Right, so that's good to know. And they take away some of the pressure from the emergency medicine departments as well, because you might see little cuts and bruises otherwise that fill up the ER, and then you can't take care of extremely sick patients.
Yes, it's important to recognize like all of these different care areas are on the spectrum are important. Everyone does heavy lifting in our society and our communities.
Right.
I appreciate that you're asking about it because it can be difficult and confusing sometimes for patients to figure out how to match up their injury or illness or chief complaint with the right kind of care.
Right. That brings me to the next question, which I think is really important. I noticed that the CDC did a survey and they listed the top 10 reasons why people go to hospital emergency rooms. And so I'd like to go over those with you.
Sure.
Because that, I think, will help people out there decide if they're sick enough to go to an emergency room in a hospital, or whether they can go to an urgent care facility in their neighborhood, or maybe even wait a few days to see their primary care doctor. So the first most common reason was stomach and abdominal pain. Can you tell us, differentiate between what types of abdominal stomach pains you should go to the emergency department of the hospital versus seeing your doctor or an urgent care facility?
Yeah, so I think we should preface all of these by saying we're going to speak in generalities,
right.
Without knowing the specifics of what someone's complaining of or their history. That would definitely sway my guidance one way or the other.
Right. So these are just general information, knowledge, education, not specific things, specific medical advice for every person out there.
Exactly, and also it depends on your age group. It also depends on your comorbid conditions or past medical history. Extremes of ages, very young and very old people generally are at a little bit higher risk for some common complaints, and we should generally default to the emergency setting. The other thing is like I said, is medical history. So somebody who's had complex surgeries in the past, somebody who is immunocompromised, whether it be from an autoimmune disease, a medication they're on, an infectious disease. Those patients, again, I would generally kind of default to an emergency setting for a quicker, more thorough screening. So what's the first one?
Yeah, so that covers the stomach and abdominal pains to a great degree. It depends on your history, what medications you're taking, how severe it is.
Yes, exactly. So I would say, something like a traveler's diarrhea with abdominal cramping, no fever, no significant dehydration. That probably is appropriate for an urgent care setting. On the other hand, somebody who's profoundly dehydrated, who is having severe abdominal pain with fever, that patient likely will need lab work, IV fluids, perhaps even abdominal imaging, and probably should start in an emergency setting.
Right. Good points. Good way to differentiate. The second item they had was chest pain. Now, chest pain can be caused by a lot of different things, some of them severe and life-threatening, and some not so bad. What are the most common things that you see that are causing chest pain, and which chest pain should go to the ER versus waiting or seeing an urgent care facility?
So chest pain is a complaint. There's so many things going on in your chest, and so
Right.
so much anatomy, and so many possible causes of chest pain, and so many of them are serious and potentially life-threatening that you'll find ER doctors and urgent care doctors taking chest pain as a very serious and complaint until proven otherwise. I would say, unless you're certain that the pain is from a problem with your skin, or from like a pulled muscle or a musculoskeletal complaint, I would say almost all those could go to urgent care. I would say almost all other chest pain should probably just start in the emergency department or call 911. Things I worry about with chest pain are heart attack.
Right.
We call it acute myocardial infarction. That's where a blood vessel is blocked off and part of your heart is not getting enough blood flow or oxygen. Quickly damages your heart muscle. You can have a problem with your aorta, which is the great vessel, that the main artery that comes out of your heart and supplies your body. You can have a collapsed lung. You could have pneumonia. These are just a few things that you can have
Right.
fluid in your lungs. These are a few things that I think about right off the bat that can be quite serious and even life-threatening quickly.
Right. So in general, unless it's a superficial skin problem or you were playing tennis or baseball too much and it hurts,
Yes.
all other chest pain should go to the emergency
I would have
room,
a
'cause
very
it could
low
be a heart
threshold.
attack or something
That's
very
right.
serious. What about shortness of breath? That's a symptom that can be caused by lots of different things. How would you differentiate that, and which of those cases should go to the ER versus urgent care facility?
Yeah, so somebody who's at rest, who cannot catch their breath, and they should go to the emergency department. Again, there's just too many causes that can quickly deteriorate. Again, that person could be having a heart attack. That person could have a collapsed lung. That person could have a blood clot in their lung. So somebody who is at rest and really is short of breath, maybe even pale or lips turning a little blue, confused, that would be called a 911 for an emergency evaluation. Now, if you're at rest and you're not feeling short of breath and you've had a recent head cold, kind of standard virus, and you're feeling like some kind of chest congestion, but you're not really having respiratory distress, that may be a patient who is appropriate to start in an urgent care setting for screening and treatment.
Right. So the critical thing that you mentioned, which is a very good point, if you're resting and you're short of breath, that's a serious problem.
Yes, and not to say that exertional shortness of breath is
Yeah.
fine, but somebody who is kind of hanging out and really is having a hard time breathing, that's an easy trip to the emergency department.
Right, best thing to do. What about coughs? You mentioned coughs earlier. When is a cough just something that takes time to go away and you might see your doctor in a few days versus a cough that gets you to the ER?
Mm-hmm. So I would say cough with profound shortness of breath probably should go to the ER. A lot of cough, if patients are able to, if you're coughing at night and it's bothering you, if you are able to, but you're able to speak fine, you're able to swallow fine, a lot of cough is appropriate for urgent care setting. Patients who are quite short of breath, who are confused because they're not getting enough oxygen, patients you're concerned are coughing because of a upper airway obstruction, that should be a 911 call.
Right. So what about if you're coughing up like green mucus or phlegm or coughing up blood? Those would be things to go to the emergency room?
Coughing up phlegm, that can be from there's quite a spectrum of disease that can cause that. I don't think coughing up gunky looking, colorful phlegm necessarily means you need to go to the ER. Coughing up blood, particularly large amounts of blood, the ER is the right spot.
All right, good points. What about headaches? Headache is one of the most common symptoms that all doctors see. A lot of my ophthalmology patients have headaches. When is a headache something severe that needs to go to the emergency room right away versus something that can wait?
Yeah, so I think it depends on, again, this is speaking in generalizations.
Right.
Headache with additional features, somebody who's confused, can't see, can't speak, vomiting, fever, certainly those that are very abrupt in onset, where you feel like you got cracked over the head with a bat or a mallet. Those
The
are
worst headache of your life.
exactly. Those are easy. That goes to the ER either by ambulance or by urgently by car. More low-lying headaches that have been going on for some time. You're able to walk, you're able to speak, you're able to go out to lunch or go to work. And maybe it even responds to some over-the-counter medicine like ibuprofen or acetaminophen. Those may be appropriate for primary care or urgent care as a starting place.
Right. So if you have a headache with any vision problems or speech problems, that could possibly be a stroke, and then you should go to the emergency room right away.
Yeah, certainly with fever, confusion, kind of inability to function. So somebody who looks sick and has a headache should come to see us in the ER.
Right. Again, I want to stress these are all general recommendations, not specific, because we don't know the people out there, their medical history and issues. But this is very good general advice for people. What about general body aching pain? When is that something that's urgent for the ER versus something that can wait? Some people, I have patients who complain of sort of total body pain. Every joint hurts, every part of their body hurts. When is that serious and when can it wait?
That's a very generalized complaint.
Right.
And a lot of things come to mind that can cause it. To me, the kind of overall body achiness, that's to me the first thing I think about is a viral syndrome or a virus, where like the flu. So I would say that those patients, first I would try taking some ibuprofen, and then I think most of those patients, as long as there aren't any other significant symptoms or complaints, would be okay for screening in urgent care. Certainly there's some other more complex disease processes, in the rheumatology, autoimmune, musculoskeletal world that or area of diagnoses that may need to be evaluated. But a lot of kind of muscle aches and pains are okay for a less emergent setting.
Right. I've had a few patients recently. Actually, I saw one today, an elderly woman who came in a few months ago with total body aches and pains that persisted. She had trouble moving, and I thought she might have PMR or polymyalgia rheumatica. I sent her to the emergency room to have a blood test, a SED rate, and a CRP test, and sure enough, it was positive. And she was diagnosed with that and had to go on steroids. I saw her today. She's feeling much better on steroids. So that's an example of total body aches that do require going to the emergency room.
And she's lucky that she had you taking care of her.
Yeah, she was lucky. I was lucky that I diagnosed it, because that can lead to some serious problems. But she's doing much better.
One thing that we see with some frequency in the emergency department is called rhabdomyolysis, and that comes from muscle breakdown. Generally, most commonly we see people who really have exerted or overexerted themselves in exercise, whether it be extreme weightlifting, maybe you haven't done a spin class in a couple months and you do a really hard spin class, or run a race or run a marathon, where your muscles actually are starting to break down. That it can be real painful, present as muscle aches and pains, and it's important that you're seen, because generally those people need some fairly aggressive IV fluids to get that flushed out, get themselves feeling better, and protect their kidneys.
Right. You can sometimes see your urine turns kind of dark
Absolutely, yes.
red from that, because the muscle breakdown gets into your urine. So
any history like that, I would say come to see us in the ER.
Right. What about back pain? That's another common symptom that lots of people have. Most of it is kind of chronic, and then you don't need to go to ER. When do you need to go to the ER if you're having back pain or neck pain?
So this is a hot topic, because we see a huge number of patients in the emergency department with back pain, and people, this is a big one, people start Googling and reading about all the worst case scenarios.
Right.
And people read that they need an emergent MRI, need some imaging right away for their back pain, which actually isn't the case in most people with back pain. A lot of back pain with time, a couple weeks, some anti-inflammatories like naproxen or ibuprofen, a lot of it gets better. So a large majority of back pain is okay to be seen in an urgent care setting. The people that I would say need to come to the emergency department are people who can't function. So if you aren't able to get up and walk, because your legs either feel weak or like they don't work, and anyone who has bowel or bladder changes in association with back pain, we get really worried about. And then lastly, I would say severe back pain with fever. Is another ER visit, because you could have something going on with your spine. It also could be something going on in your belly or flanks that you think is back pain, but you need to come and let us figure that out.
Right. So if you have any paralysis or weakening of your arms or legs or other problems, then you should come in, because there might be something pressing on the spinal cord.
Exactly. Yep.
Right. All right. What about vomiting? That kind of goes along sometimes with abdominal pain, stomach pains. When is vomiting significant? When is it something that can wait?
So I think it depends on the severity and the frequency and kind of what else is going on. So people throw up. There's a lot of reasons why you throw up,
right,
or vomit.
Could be a bad meal.
Could be a bad meal. Could be something didn't sit right. Could be a viral infection. Could be too many glasses of alcohol. There's a lot of reasons why people vomit. I would say most people are going to be okay if they vomit a couple times. And then are able to then tolerate fluids and kind of keep moving. Sometimes that takes 12 to 24 hours. The people that I really start to worry about are people who are vomiting blood, particularly large amounts of blood. Also people who are vomiting so much that they aren't able to hydrate. So you pretty quickly can become dehydrated if you're repeatedly losing all of that fluid, and those are the patients that I worry about and should be in the emergency department setting.
What about people sometimes say they have projectile vomiting? Does that help you differentiate things, or that could happen in any case?
Yeah, so there's a problem called pyloric stenosis that happens to small babies. We listen for and look for projectile vomiting to quickly figure that out in that population. So projectile vomiting in an infant or neonate really perks up my ears. Projectile vomiting in adults like you or me generally doesn't mean a lot, to me at least.
Right.
It would matter to me more about was there blood and how often is it happening.
Right. And I've read, and the CDC says it as well, there's a huge increase in number of visits to emergency rooms because of mental health issues. Are you seeing that, people coming in because of various psychiatric or psychological problems coming to the ER?
We do. Psychiatric and mental health complaints are a very common chief complaint in the emergency setting. Similar like we talked about at the beginning with primary care, I think the uptick in mental health visits in the emergency department has to do largely with access to reliable, ongoing outpatient mental health and psychiatric care. So we see a wide variety of mental health concerns, quite a bit of anxiety, and that's generally well managed, and we can plug patients into resources as an outpatient. We see a fair amount of depression, and then we see some people who are quite sick and require hospitalization. So it really really is a wide range of problems, and then also care pathways for what's going on. I would say, other than kind of low to moderate level anxiety, a lot of mental health should be seen in the emergency department rather than urgent care.
Right. So again, it depends. And there's a psychiatrist available in most emergency medicine departments if needed?
Yeah, so most emergency departments have a number of different mental health professionals, whether it be a social worker, a psychiatrist, psychiatrist residents, or APPs like nurse practitioner. So you may not be able to walk into an emergency department and expect to see a psychiatrist that afternoon or that evening,
Right.
but certainly there are mental health, part of the comprehensive mental health team that can screen for serious illness and make sure people are safe and the right care is initiated.
Right. I interviewed a psychiatrist a couple of months ago who specializes in addiction issues, and she mentioned that there's increased cases of psychosis from marijuana use. Have you seen that in the emergency room?
We have seen some. I think we used to see it more. There are some synthetic marijuanas that are known to cause quite intense psychosis. Since some of the synthetic marijuana use has declined, I think I don't know the statistics, but anecdotally from my practice,
Right.
I've seen actually a decrease in that. I've seen an increase in marijuana use, but it's true marijuana and not the synthetic product that is known for psychosis.
Right. Now, interestingly, the CDC didn't list stroke as one of the common things, but anybody who's having a stroke should immediately go to the hospital emergency room. Can you tell us what the common symptoms of a stroke are, and why people should go to the emergency room right away when they have those symptoms?
Yeah, so there can be quite a number of different symptoms that can signal us or signal people to think they may be having a stroke. Some are more subtle and some are quite profound. So anything that changes kind of your sensorium, so people who are suddenly off balance, have abrupt onset dizziness, inability to speak, or kind of jumbled nonsensical speech, so speech changes. Also vision changes, like loss of vision in one eye or loss of a visual field. Those are symptoms of stroke that would make me really concerned and should be a call to 911, not just come to the ER, but should be a 911 call. Additionally, if a limb, arm and or leg is not working, whether it feels weaker or is flaccid or has numbness or tingling, these are all signs and symptoms that may represent an acute stroke. And the reason why I say call 911 and not just come to the emergency department are two. One is EMS is plugged in, is really part of the comprehensive team of stroke care, and once EMS recognizes a patient may be having a stroke, they can begin to activate a whole system of care that is time sensitive and will line up even prior to your arrival in an emergency department. Additionally, there are several different interventions, whether it be removal of a blood clot or administration of clot busting medications, and those both have very finite time requirements of when they can and cannot be administered. So stroke is really something that's time is of the essence, and you need to get to care quickly.
Right, and the quicker you get there, the window of opportunity for treatment is better.
Yes, and the outcome will be better.
Another thing the CDC didn't mention, but there's been an epidemic of drug overdoses, fentanyl and other drugs, about 100,000 people a year dying in the USA. from drug overdoses. Are you seeing that in the emergency department as well?
We do see that, and we see kind of all spectrums of disease from early users, acute users, chronic, people who use these drugs chronically, and unfortunately we even see people who come to us in cardiac arrest having overdosed. We're taking a multi-pronged approach. I'm proud to say that our department really has worked hard on drug use and particularly like opiate use disorder. The other thing I know is in the news a lot, and many people are aware of, is that medications, opiates such as fentanyl, are being cut into other drugs. So people use a drug like cocaine, expecting an upper, and maybe don't know or is not recognized that a medication like fentanyl, which can be a heavy respiratory depressant and mental status depressant, is in that drug at lethal doses. So we have done a number of different things aimed at harm reduction. We are giving, we have the ability to provide test strips for fentanyl so that people can utilize the test strips on their drug supply and understand if the fentanyl is in there, as well as a new emerging problem called xylazine. And the other thing that we have the ability to do, and this is, New York City as a whole has done a great job of getting Narcan into our community. So we have the ability to provide Narcan rescue kits or Narcan reversal kits, and that's the medication which can be administered by anybody to anybody if you think that the person is having side effects or change in mental status or breathing ability due to drug overdose.
Right. I think that's available over the counter now in drugstores, right?
It's available really in a lot of places, which is really quite a success story. It's a bit, like I said, we can provide it to our patients at time of discharge from the emergency department. Many health departments in the country can help people with access to that life-saving medication.
Right, that's great. So on the other end, we've been talking about patients now and the public and what they should do. Tell us what it's like to be an emergency medicine doctor. It seems like extremely stressful. It's very time-consuming. There's lots of deadlines. You have to act immediately. You have to do the right thing right away to save people's lives. There's also families there who come in with somebody who's deathly ill. How do you deal with all that stress and all of those deadlines and emotional issues?
Well, one way that I deal with it is I make sure that I have a lot of fun in my life when I'm not at work. And I make sure
that works for a lot of things.
I make sure I get a good night's sleep. I spend a lot of time with my family and friends, and I get outside and exercise. And so part of that is just is having a great time outside of work.
Taking care of yourself so you can take care of other people.
Absolutely. And then in the emergency department, it's a fun place to be. You really we are really well positioned to understand what's going on in society and understand
right.
the successes and failures of society and of our communities, and figure out how we can help people. I always say, each patient that comes in, I'm trying to figure out when they leave me, how can I make their trajectory a little bit better? That's for all people and that come to us. And the other thing I think most ER doctors will tell you is we really feel privileged to get to take care of all ages, birth to death, with
right.
all problems. So we evaluate every system in the body and every age group that there is. And last, kind of overarching themes, I think in the emergency department, we feel really lucky to get to be with patients and their families at a really tough time. Nobody comes to us because it's planned,
right.
and nobody comes to us because their day is great. And so I think we all have a sense of pride and a sense of duty to being with the patient, with patients and their families during the tough times.
Right. Yeah, you have to take care of yourself so you can help other people. Now, you brought up 911 or ambulances several times. And how does a patient know whether they need to call the ambulance or whether they can take a cab or an Uber or bus or have their family drive them to the emergency room? Are there any general rules that are helpful?
So patients who can, people who can get up from a chair, walk and talk and are of a normal color, normal mentation, meaning you speak to them, that makes sense. They can carry on a conversation. Again, have kind of normal respiratory effort, normal skin color. Most patients who can do that probably will be okay getting to an emergency department or urgent care, as we discussed, by self-transit, whether that be walk, cab, car. For patients who are confused, who aren't the right color, who aren't able to get up, there's a mobility problem either because of injury or because of profound illness. Those are the types of patients that I think 911 should be called, not only for prompt care, but also for the ability for the EMS, which often includes a fire crew, to be able to transport that patient out of whatever situation they're in safely into the emergency department and initiate care.
Right.
Does that make sense?
Yeah, it makes huge sense. Again, if you're having a heart attack or symptoms of a heart attack or a stroke, urgent care is critical in saving you and prolonging your life. So,
yeah, those are emergent problems.
Right. Plus, an ambulance can get you to the hospital quicker than if you're in a regular car stuck in traffic. So that's very important. Patients occasionally tell me that they had some urgent problem and they took a bus or a train or whatever and got into trouble and possibly collapsed or fainted on the way. So very important to call the ambulance for something critical. Now, you're involved at NYU with a health equity initiative. Can you tell us about that and how that's very important?
Yeah, so we in the Ronald Perlman Department of Emergency Medicine are working hard to understand ways that we can serve our communities and the populations that we see in ways that move beyond more, well, I'll call it standard emergency care. We're trying to understand how to maximize the time that patients are with us and see if we can take care of them and recognize disease processes that that are outside of traditional ER screening. Specifically, we in 2019 we started a project with diabetes screening. So undiagnosed diabetes and untreated diabetes in the United States, and specifically in the communities our ERs serve, can have a real impact to people's overall health. We call it morbidity and mortality. So it can increase bad diabetes or undiagnosed diabetes can increase risk factors for many other diseases, including kidney failure, stroke, heart attack, in your wheelhouse, vision changes,
right.
vision loss. So we have developed a screening program where patients who come into our emergency departments who don't have any history of diabetes and are having bloods drawn, we screen patients according to the American Diabetes Task Force screening recommendations while they're with us, and then we can let them know that they've screened positive for pre-diabetes, and we provide information and resources for diet change, exercise, weight loss, or patients, the lab results look like they may have a new diagnosis of diabetes. Similarly, we can initiate diet and exercise guidance and plug them into to ongoing outpatient care, kind of as a bridge to care.
That's great. So not only are you taking care of their acute problem, but you're also steering them in the right direction so they can take better care of themselves and avoid future emergency room visits for problems that could have been treated.
That's right. So we're taking care of the acute problem here, and then also trying to do in any ways we can kind of think upstream to take care of head future problems off at the pass. And this model that we're using for diabetes screening, we're actively trying to understand what other disease processes can follow that same model for screening, such as hepatitis C.
Right. That's really important. I think some of the public may not get that when you get to the emergency room as a patient, not only are you treated for an acute problem, but then the emergency medicine department provides you with access or ways to get further care to treat the underlying problems and issues so you don't wind up in the emergency medicine department again. So my patients who've been in the ER always show me papers and things that they got, and they've gotten appointments for other doctors so they can take care of their problems. That's very important, and it's great that you do that. Are you involved in teaching as well at NYU Langone?
Yes, so we have, as we discussed, we have a large residency program, the NYU Bellevue Emergency Medicine Residency Program, and we have residents on every shift, and those are people who are post medical school and are doctors in their training, becoming specialists in emergency medicine. They're with us for 4 years, and we work alongside them clinically, seeing patients with them and developing assessments and care plans together. And then we also have a number of other different learners around, like medical students, for example, nursing students. Sometimes there are pharmacy students. So we are a teaching institution, and so we're an education environment, and we have learners every day.
That's great. What about research? Is the department involved in research? Are you involved in any research?
Yeah, absolutely. We have some. We have a robust group of researchers in our department. There's kind of big research and little research. So when I say big research, I mean some of our experts who have large nationally funded projects and grants. We've been speaking about opiate use disorder and homelessness. Our department has some real experts in those areas and are doing some pretty profound research. Then you have kind of little research, people like me that do some much smaller scale projects, looking at emergency department operations and delivery of care.
Very important. You've probably seen last couple of weeks that there's been some news that there's a new flu strain out, the H5N1, or sometimes referred to as the bird flu. And apparently some people have caught it now from cows. I think one person actually developed an eye infection, a conjunctivitis. And there's some people who think this might be the next pandemic. Hopefully not, but there's a small possibility. Are you prepared for that in any way? Because if that becomes transmissible from person to person, the emergency room could be overwhelmed with very sick people.
So yes, we really, COVID has taught us that we need to stay together, we need to share information, and we got to stay up to date. Certainly people were doing that before COVID, but now we're doing routine kind of huddle phone calls with a large number of leaders throughout our health system, led by our epidemiologists and infectious disease doctors. They take us kind of across the global map and let us know where emergency diseases are. We get up-to-date information from them so that it remains high on everyone's radar. We do drills, so we have actor patients who present with a chief complaint that may represent an infectious disease, and then we as a team practice on where's the right equipment, how are those patients isolated, how is it recognized, what specialists are needed to identify what's going on. So we we have diseases like mpox, measles, flu, as part of our regular conversations, so that it remains at the forefront of everyone's mind, and we're fluent in what to do.
So you're ready for the next pandemic. Hopefully there is none, but you're prepared for that if it should occur.
Yep.
It's comforting to know. Great to know. This has been extremely informative and educational for me, and I'm sure for the people out there as well. So I really appreciate you coming today and speaking with us at the Doctor Podcast program. Thanks very much.
Thank you very much.
All right.
Thanks.
Thank you.